Good morning and welcome to our monthly live broadcast for the endovascular cases from Mount Sinai Hospital here in New York City from the Department of Interventional Cardiology and Endovascular Interventions. I'm your moderator for the day, Vishal Kapoor. And as in how the year comes to an end, we start getting more and more interesting cases. So today is another fantastic case brought to you from the cath lab led by Dr. Krishnan and his team. And another great example of how collaboratively we work, both from patient care standpoint as well as physician, where we have our vascular surgeons come in today to help us out with this complex iliac cases and hopefully guide us and have a successful case. So we're going to go over directly to the lab. And good morning, PK.
Hey, good morning. Thanks so much, Vishal. We have a great case here that we're already struggling with, which we know we probably will. But it's part of the fun, right? You get your price of admission here. So we have a case here that's going to be really kind of demonstrative of our endovascular field, where not all cases are best for endo, and a hybrid approach should also be something that we should also always be considering in terms of what's best for the patient. So it's my pleasure, as always, to welcome Dr. Ajit Rao here, who's been in so many of our live cases and so many times, and has supported us, so he's here. So he's to my right, and then Dr. Karthik Guja, unfortunately, is stuck in a little bit of traffic. He's on his way, and to his right is Ajit's fellow. What year are you?
Fifth year.
Fifth year. Wow. So he's ready to go out and tackle the world, Chris. And then we have Ray Lascano, our endovascular nurse practitioner. And then we have Shalini, one of our endo fellows. We are very grateful to have anesthesia here and the team who got up early for us to support us in this case. And of course the incredible endovascular team with Damien oh yeah, shoot, I came back. Hold on. Damien, Peter, Alina, and Mac. So we've got a fantastic team here and a really tough case. So Shalini, can you please go ahead and talk about this case? Ray.
Yeah, good morning, everyone. Where is the...
Okay, give me an Amplat super stiff, please.
History of presenting illness. Our patient is a 78-year-old gentleman who's referred with lifestyle-limiting claudication progressive to Respine Rutherford Grade II Category 4.
One second, we'll make a curve.
And the past medical history is notable for diabetes, hypertension, hyperlipidemia, and stage 2 CKD. In terms of medications, he is on good Glucophage, Hydrochlorothiazide, Amlodipine, and Zocor. The initial non-invasive vascular diagnostic revealed an abnormal ABI in the right side, and the Duplex ultrasound was revealing severe stenosis in the iliacs and total occlusion of distal tibials. And going forward with the peripheral angiogram, this is the peripheral diagnostic angiogram, which reveals the occlusion of right external iliac up to right common femoral with the reconstitution from the right SFA.
Nice.
So the pre-op planning included CT angiogram, and this is the CT, which demonstrates a normal ascending and thoracic aorta, and a normal caliber mesenteric artery. Here is a normal renal arteries, and a normal caliber distal abdominal aorta. Which is bifurcating into iliacs. And here's the right external iliac occlusion with calcification and tortuosity seen in the CT. and we decided to go ahead with the hybrid endovascular intervention and revascularization of this case.
So do you have pictures of the angios or no?
I showed them.
You did.
Yeah.
So again, as the audience can see, Vishal, we have a case. I think is it coming back now, right?
No, it's good.
Yep. The angiogram picture.
Is it gonna go? Go AP here. Yeah, I'm sorry. We're just trying to get the sheet up and over. Yeah, show the angiogram here.
All right.
Is it gonna go? There you go. Wow. All right. I think I'm gonna now telescope it.
Yeah, so as you can see, it's an interesting case. I have Dr. Raman Sharma joining us as well, so it's a pleasure to have him on board.
Good morning.
Good.
So
Right
for the audience, as you can see, since we have
Okay.
the vascular surgeons there, we actually, if I'm not wrong, Ajit can explain it better, but we actually did a cut down of the left common femoral. So there you can understand the complexity of the case itself and the approach, like PK talked about, patient-centric
we need to
what's
give
best for
heparin,
the
guys.
patient.
Here
And
is the
seeing
supracor.
the
How much heparin you
lesion
want?
disease process, I think it's a
How
tough
much does he
lesion
weigh?
to go up and over and try to fix it.
Yeah. So I think Ajit and
6,000.
I have spoke about this case.
Yeah.
Do you show
6,000
all our
heparin.
diagnostic angio, my dear? You
Yeah.
showed all the okay, good. So we went ahead and took some pictures, and I just want to show you now. We got our 8 front sheet up and over, and I just want to make sure. I'm in the internal still. So I need to just pull back. There you go. Perfect. So this is our anatomy here. So I'm just going to show you, and you can see why we decided to cut down. So you see the internal iliac is there. The common iliac has no obstructive disease. We have actually a pretty reasonable little cap, but I may not be able to get through it.
Yeah.
And now you can see the level of calcium. Put me on coronary, Ray. I just want to show you the level of calcium, and and I think you could see here now. Do DSA? You can see this patient. Obviously is a very severe claudicant, has multi-level disease with this, as well as the external iliac, and then he has a very good, robust SFA down to the foot. You showed that right earlier.
Yep.
Okay. So now we're here, and Ajit, can you talk about why we decided here on to go with the hybrid approach?
Yeah.
Stiff
So
glide,
this is
straight
definitely
aversion.
a very complex case. It's basically an iliac CTO that involves the entire common femoral artery. So in these cases, I think hybrid approach is kind of the sweet spot because you can do a cut down on the femoral, do an endarterectomy, and then you can fix the iliac endo. I think if this lesion ended in the proximal common femoral or distal iliac, then you could probably just do endo.
Right.
But the fact that it involves the entire common femoral and then really up to the bifurcation, I don't think endo, you can't really fix this with endo without stenting the common femoral, and that, wouldn't be great in this patient.
So Ajit, why did we discuss to go up and over attempt from antegrade rather than start retrograde through the cut down?
Yeah, so this is
Straight glide.
unfortunately the common femoral when I cut down on it felt like a tube of calcium.
Right.
Scary.
So I was kind of hoping that it would just be one focal lesion in the common femoral that maybe shut down the whole entire vessel, because there's no outflow, but the whole thing is
Straight
like
leg?
disease and probably full of plaque. And so it's going to be really hard to try to get a sheath in retrograde and then advance it all the way up. There's just, I'm not sure if I can even do that with like any sort of wire. So I think trying from antegrade, especially the good thing is we have that little nubbin at the proximal external iliac, so we have like a little bit of a running room to try to cross it from antegrade.
The problem with that, Ajit, is that you've got a lot of issues in terms of the nub is not. It's like a blunt nub. It's not like a flat nub, And I think that's an issue right there. Go ahead, Ajit. You want to push?
I think that's an important point from a surgical perspective about the calcification, because me and Raman were discussing before
Like
like
this
how
catheter
aggressive
devices?
we can
Why
be.
not, right? Yeah.
The lumen size of the SF is almost a 7.0, so we can both also get a SFA stick, which is non-disease portion, have our retrograde access and try to do it. But like you said, in this case, because the CFA is so densely calcified, would be like a
I can
hostile
jam it in
ground.
if you want, but it's not.
and probably
It's
not
straight.
look
Maybe
good to
straighten
the
it a little
patient
bit.
from purely an
It's not straightening,
endovascular
yeah. Let's get a straight
perspective.
catheter
Raman,
here.
What do you think?
Yeah, I mean, this is
Straight aqua.
this
Straight
is a
aqua.
doozy of
No.
a case.
Yeah.
I think that that's the medical term for it. I mean, obviously
straight
a case
cath.
like this requires so much planning and considerations. I think the one part which has
Should I get a
allowed
feedback
so
or
much
something?
conversation was the fact that the
A feedback?
profunda was
Like a
not
needle?
involved.
Correct.
And the fact that the profunda is not involved really
Damien, do
gives
we have
you
the
so
feedback
many
catheter?
more options. I think if you
Oh, the
did,
wingman?
if you had true profunda
You want to try an own force system? Or
involvement,
Yeah, we can.
I think you would maybe even consider just like staging it, or just do a endarterectomy and then just like a fem
Yeah,
or
straighter.
something like that.
Yeah,
But,
that's
but again, there's the other surgical options too. I think that I like the idea of like maybe an SFA retrograde, but if you're already going to be committing yourself to some degree of
Nope.
an endarterectomy, I do like this hybrid approach.
Right.
But Ajit, from a surgical perspective, in terms of the order in which the procedures
Wingman?
are done, if you were to be
Fine.
doing, I've never performed an endarterectomy despite my
We'll get a
random
one for
desires
wingman.
to do so.
Poke a
But
hole.
if you were to do
Poke a
like
hole with the wingman.
a small cut down where you expose a common femoral, could you nub for French sheath something through the calcium that you can be more aggressive to make a small channel through the actual the calcific pipe that you're feeling, and then retrograde cross?
Yeah,
I feel as if this would be more of a challenge to cross antegrade
Right.
than it would be
Well,
retrograde.
well, I think the theory of crossing. And can I please have that thing? The theory of crossing antegrade is important. Important because the idea here would be to capture the wire, and then externalize the wire, and then go ahead and then sew the patch onto the stent graft, which I think would it be easier to do if we crossed antegrade?
Yeah, so exactly.
have
The
the
way
needle.
that I've done these sometimes
Now you have
is
the needle. You can just push forward. See, let me. So we're using the go back catheter. Go on coronary. Ray, I need you here, please. Go on coronary.
Yeah, coronary.
Okay, so we just have the go back catheter here. We're going to try to poke a hole, little die, guys. So I'm just going to try to torque it.
Guys.
let me know when you want me to.
Yeah, I just want them to see it.
Yeah.
So okay, now I'm just going to push this catheter forward. Now Dr. Ra is going to push the needle forward.
Yeah. Can we talk about a little bit detail about the
Right.
catheter you're using? Yeah.
Yeah, it's the go back catheter. We're just trying to pierce it, but it's going off to the side there. You see that?
Wanna
So
give a
I
sheath?
think it's because of the sheath is biasing us.
Correct.
So let's see if we can poke it with the needle. I'm just going to go forward.
And what kind of wire do you have in the catheter?
It's an 014. See, it jumped out now.
Yeah.
Guys, give us a little die now. I want to make sure we're not coming off into the subintimal split. That's probably okay.
Yeah.
Right?
doesn't
Now,
look
why don't you give
terrible.
us a command so we can loop? Go with the command wire. Because 014. Or, So we're trying to do a dissection here and see whether we can get in through a dissection. Are you okay with the angle legit there?
Yeah, it's a big vessel, so I think we're okay for now.
Right.
Okay.
But yeah, to answer your question, the way that I've done these is I'll stent, usually like a Vibon. You want to use a self-expanding stent so you can clamp it up to the common femoral, the origin of it, and then you just basically endarterectomize to the stent. So that's
Yeah.
the way to do it antegrade. The other way to do it is to do the common femoral endarterectomy first, but the problem is like
We
you're
use
just
this as
pulling
CP12.
out plaque proximally without really a
CP12.
good endpoint, and sometimes you can
That's
cause
true.
a bad dissection, and then you can't really cross it retrograde anyway. So I think this is probably the safer way to start.
That's true. And I think in this case also, it's like Raman talked about, the profunda is not really
you're
involved.
out,
It
right,
looks
you're out.
angiographically not as
Now
involved.
try.
So it saves you the profundoplasty part of the
push.
endarterectomy. So it's
It's probably
mainly
maybe a
common
spiraling,
femoral,
huh?
truly common femoral lesion.
It looks like a
with
bad dissection.
fortunately
though.
not extending into the true
wanna
SFA
try a
and the
different one?
profunda
Then
as
we have
well.
to pull the catheter
But
back.
I
then.
think here you could be aggressive going subintimal because we have a surgical cut down at the end. We could probably
Try now?
expose it and, like
It's
you said,
probably okay.
externalize
See
the
where it
wire
goes?
and work on it as well. So
yeah.
it's a very
You wanna
nice way
take
to
it? No, no.
demonstrate
No,
how
looks
the surgical brains and the
like a bad
endovascular
one,
brains
right?
can work together and hopefully give a patient a
There you
great
go.
result.
Let's see that. No, same thing.
But it's
So
all
we've-
about talking about the technique. So I think PK is working on a 018 with the wire and catheter technique to try to loop it.
Yeah, we're going with the B-back catheter, and we're trying to. Let me see if I can loop that in there. It's not going. And we made a hole, but unfortunately, we're not able to get into the lumen. Well, let's give it a little die, Ray. No, it looks like a very bad dissection.
Yeah, looks like we're.
Do you want to go with a glide wire now and see whether it kind of pops?
Yeah.
Yeah, we.
Go with the
Try
glide
that.
wire and a catheter.
Straight
You want
leg
to try
or
poking
stiff
around a
leg?
little bit more? Or you
Yeah,
think?
we can. Let me come in.
Yeah, I think that's a very
I have
important
to,
point.
but I don't want to pull the sheet back. That's the problem, you know.
It's like how aggressive you become and how
So
early
you know what?
aggressive
Can
you
we
become,
load
I
this
think.
inside a steerable
sure.
catheter,
I
Ray?
mean, maybe I'm
Let's try.
missing
Let's try to
something
load
here.
this.
But if you have the
Give me
common
a
femoral
vertip catheter.
exposed, why can't you
Pull the
be
wire
super
back.
aggressive in a retrograde cross?
That's a
As in,
good
just
point.
go with a cook
Good.
needle and
Or
just
give me
jam
this
it
vert tip
what you
catheter.
know
Yeah,
is going to be
same.
dead center
Right.
in the vessel, and just go
Let
with
me just see
a
tip
stiff
tips.
glide
Sure.
and just dissect all the way
Okay.
up to a point in which you can insert
So,
like a 4 French sheath or
Wet one,
something,
guys.
and then try to externalize somewhere in the external.
right. I think the biggest concern is going subintimal and then
Working.
crossing
Oh,
over
shit.
and having the internal on the subintimal part of it. Because you're right, we have an exposed CFA. So if you try to go into the lumen and let's say we enter subintimal, you have to re-enter there.
But
While going from the
but
top,
you would enter with your needle in the
Okay.
true
Ready?
true,
lumen.
true
Gonna go
lumen.
with
But
this, and then you
it doesn't,
figure it out.
we don't know how the wire is going to behave after the true lumen. Hopefully you're right. It'll stay. We could give it a shot. If it goes straight up, you can actually connect the dot and externalize the wire
You
to
want
the
catheter
sheath
out or
we
the
have,
needle?
an 8
No,
French sheath we
catheter
have up
first,
there,
right? And then
which
come
I
with
think
the
is,
needle.
is a good option
And then
to
come,
agree.
and then
And
we'll
that's the
pick
reason
a
I talked
spot.
about getting a retrograde
Yeah.
SFA. If you really
me a little die,
touch
Ray?
the CFA, 7 French, and we try to do it the same way. So what
Let's
you're
try
talking is
there.
just a little bit higher level, which I think would be a
Okay.
good
Not
alternative
catheter,
strategy. But
not
I
the
think he
wire.
was hoping that the cap
That's
so
the wire.
going to the C top is
Yep.
favorable, even
Needle's
though it's
out.
blunt. It looks
Not going.
chronic, calcification there,
Nope.
but we don't have much
No?
support, like as we can see with
None.
Needle? There you
with
go.
the sheath, and it's actually biasing you to a side of the wall you don't want to
Nope.
go. So I think that's where the issue is. So it's a
No,
possibility,
that's
like
same
Raman, your
spot.
prediction might come
that's
that
the same
we
one from
might
before,
just
right?
stick the CFA and just go
There you go.
up
That's
and
better.
try to connect the dots.
No,
But
hold on. Okay.
it's worth a
Not a
try,
little
I
die,
guess.
Ray?
But I
Actually,
think
let's
these
go
are all
low
important
mag.
points to consider when,
So-
especially we're doing these complex cases.
So some technical considerations here. What Rajit and I did was we loaded the B-back into a 035 catheter and actually steered it. And you can see we're in a better plane coming towards the
Right.
common femoral.
Yeah.
So I'm kind of
Yeah.
going to like this here. I'm just going to push my catheter forward, Rajit. You okay with that?
Yeah, I agree.
Okay,
That looks like a good plane.
I'm just going to go right through with my catheter here. And then now
Wow,
if you
sweet
want,
like a
you can
butter.
go. If you want, you can go with another wire. You want to go with an 018 wire now?
Yeah,
to
we
get
can
a
try
feel.
something. I mean, this one, you want to see if this goes anymore?
Sure, may go. May go. There it goes. You want me to come
You-
forward
You're
with the
going to
catheter?
feel the wire at that clamp right there.
Yeah, I'm almost at the clamp is a good landmark there.
Yeah,
And then the vessel
exactly.
loops. So we're almost to where I can just endarterectomize it.
I think that's a very favorable position where the wire and the catheter are.
Yeah, so the only question is whether we should move my catheter forward and switch out to an 018 wire. You want to rail the wire a little bit?
Yeah, I think this one's not going to go
So
anywhere.
I'm just going to
Yeah.
move this forward. And then let's get an 018, get a Shahi, not a Gladius, Gladius, a Shahi Gladius.
But the nice thing about this is even if we end up in a bad dissection here, I can just endarterectomize it.
Yeah, open
So-
it up.
Yeah.
But if we did it the other way, then it could be more challenging
Correct.
because, higher risk of rupture. So this is the way to do it.
So what we wanted to do was show, first of all, this kind of retrograde crossing, which made a lot of sense to us. I'm going to hold the
I'm
wire.
gonna-
You can
just
pull it
the
out.
catheter, right?
Yeah, I'm going to leave the catheter. And so now what the idea is I want to show it live is actually having Dr. Rao and his team Chris cut down, and then capture the wire. Then when you capture the wire, then you have through and through access, and then now we can then take a balloon angioplasty and a Viabon, or we're thinking about a Viabon, and then going ahead and then sewing it to your patch, right?
Yeah, I think because we're probably in a little bit of a dissection, probably Viabon is the way to go.
That's the way to go.
Definitely no like VBX or balloon expandable
Right.
stents because I
It's
can't
free-
clamp
free
those.
shape.
They're not going to
Free
re-expand.
So,
Right.
so I think at this stage here, it's kind of understanding what your stop point is, and I think for those at home, maybe we can go a little bit over the common femoral data, because there's a lot of data with common femoral. Obviously, we have TICO, we have Tom Zeller's study with bare metal stents, showing that there may be some, obviously, actually not some excellent patency with bare metal stents, but it's still not the standard of care. That's for sure, right? So the reason I say that is because surgical endarterectomy, as the literature shows, has excellent 1 to 2 and 5 year patencies.
patency, right, yeah.
So I think that we have to choose the right case and discuss with our surgical colleagues as to tell me when you want me to push the catheter.
Yeah, what do you think about that point?
Yeah, I like that point.
Yeah.
And then and decide what's the right case for us to do. You need to push the wire a little bit more. Maybe 035 now.
Yeah, I think we might need
Yeah, give us an
035.
035 glide, guys.
Let me ask
there
you
it
Ajay,
goes.
this.
Good. It went
Let's
forward.
say you cross
No,
the
it didn't,
wire
it didn't.
and you go all
035
the way
glide?
into the SFA.
Straight or
Would your
Straight.
strategy still change?
You're right at the Oscar there.
straight.
Yeah. Close.
What is that, brother?
So I'm just thinking, let's say we cross
Yeah,
the
angle
lesion
glide.
and it just pops through the CFA into the SFA. So we cross through and through. not through externalizing the wire. Let's say the wire pops through and you go all the way into the SFA.
You really want us to stent this, huh, Vishal?
No, I don't.
Oh
I'm
my
just,
God.
I'm just being a devil's advocate.
Oh
but-
my
but-
God!
but that's-
I'm gonna
I mean,
let
but
Dr.
that-
Guja comment. Can you get Dr.
I-
Guja an earpiece?
I still don't think that would necessarily exclude the possibility for
Parker got it?
No, I'm not
Yeah.
releasing that. I'm just saying, then how far does it change any of your predetermined
I can
strategy
target the
of
wire,
saying,
the
we're still going to do
catheter
from
endarterectomy, which I'm a
Yeah.
true believer
How's
in, like
that?
we talked about.
So-
The data for endarterectomy, patency rate at 5 years is more than 90%. So it's amazing data. I mean, Ajit can tell you, but that's what the surgical data overall suggests. And like what speaker is talking about, there are trials, there are data to suggest
pretty-
that the stenting is a very good
like that one?
alternative
Yeah.
treatment strategy, not still not
calcium's
still
right
the
there.
standard of care like we
Yeah.
talked about, but we still use it in patients who are not a candidate for endarterectomy with great results. So I think in this case, like we talked about, having a good surgical and an endovascular hybrid approach
Looks like-
will give the best clinical result, give best patency result to the patient who's presenting with the symptoms.
Yeah.
But yeah.
I think the goal up front should be that the major destination therapies that you have decided, that being the endarterectomy for the common femoral, should not
better.
be
You wanna get the
adjusted
catheter
based
down or
off
not?
Yeah,
the
you want to
preference
advance it
of
because I
your
just need more
case.
pushability.
I think that's going to determine
Push
the
the wire.
long-term patency for the
There you go.
entire
There we go.
intervention.
Right.
Nice,
So I
nice.
think
All
this
right.
is something that would
I'll stop
definitely
there a little more.
Yeah, a little more.
Right
the
there?
necessity of it
You
would
want-
definitely be that we have to have the
Right there?
endarterectomy.
Yeah.
Proceed.
Okay.
Right. So Ajit, from a surgical
Save that.
perspective,
I
when
got
you do endarterectomy, I know you can extend it all the way into
There
the
you go.
external. In this case, how
You
far
wanna
are
go a
you
little
planning to
further?
extend
Yeah,
your
push.
endarterectomy
Yeah.
zone? Keep it
Right,
truly in the
good, push.
CFA, or you want to extend it higher up as well?
So, say it
You
one
don't
more
want to
time.
make it too big,
So I'm
though.
just
So-
saying,
No,
from
you
a
don't want to make it
surgical
too big.
perspective, I know when
Yeah,
you
go
do
like that.
endarterectomy, you can
Yeah. Let me
extend
get it
your
down a
plane
little
up to
closer
the
to you.
distal external iliac.
Yeah.
But in this
So-
case, what's your landmark
I think
for
you're
people
already
to
there,
know
PK.
and from a
Yeah, yeah.
from an
That's good.
Yeah, I think
perspective
So-
to see how far you're going
There
to
you
go?
go.
Right there.
Yeah, so when you do this,
Got it.
A little bit more?
wow,
Yeah, a
as
little
I'm
bit
talking, Dr. Guja is going to cross the whole thing and
I told.
fix it.
Hold on.
No, when we're doing these, you need to go high. So you want to go to
Where's the
the
sheet? You
inferior
don't see the sheet?
epigastric,
Came back, right?
because that's that transition
back?
point from
Yeah, she
the
came back.
common femoral into the
Up- up
external.
Yeah.
And then
Little
we
bit-
mobilize the
little bit
inguinal ligament because
That's
that's,
good.
a good landmark, and we really
Ray,
push
can
it
you
up.
fix the sheet,
And
brother?
you can really see the vessel kind of dive into the pelvis when you do that. But you want to go high. So I
is
got
good
really
enough,
high
okay.
exposure
Just
with
come down
this.
a little bit for you.
This one's challenging though
think
because
it's good.
I also
Leave it
need
there.
low
Yeah, I think
exposure
it's good
because I need to get to the
we're good
profunda and SFA
Right.
because I have to endarterectomize the whole thing.
So everyone at home, you saw how the sheet kicked back.
Yeah.
And so what we did was we just tracked over the stiff glide and the catheter using it as a dilator here. And now Dr. Rao is probably ready for a good spot for a cut down, right?
yeah,
Or
I
you want
could
to go
just
further?
so I guess we have two options here. Option one is just to treat
DSA,
now everything.
correct?
And then as long as we have the pushability and the wire is not buckling back,
Mm-hmm.
then I can just cut down after we
DSA?
fix the iliac, clamp the stent,
Yes.
and then do the endarterectomy.
Okay.
The other option though is if we're having trouble with pushability and everything's buckling back, then I may need to open up the vessel and then pull the wire out. But that could get a little messier just because there's going to be a little bit of bleeding and everything.
Okay.
So
So you want us to balloon angioplasty is the right
Yeah,
thing.
exactly.
I know that's exactly what you and I talked
Yeah.
about. So should give us an 018 wire now, and let's go with an 018 balloon so
don't
it's
want
going to
to
track
cross it?
better.
we can always,
018
Because
Halliburton?
you're so close, right? You don't want to cross it?
No, because I think it'll be better. Because then we'll be listening to Vishal. We don't like to listen to Vishal.
No, but even if we cross...
Karthik, help me.
do you,
No, I'm saying even if we cross it, right?
018 Gladius,
it's still,
Gladius,
it's
I'm
still
sorry,
you have an
Gladius.
It
option
gives you
of still...
support.
Gladius
It gives
018,
you
we have
support.
it.
So,
Yeah, as long as we're-
Endarterectomy, yeah.
Yeah, of course.
yeah, you can still do endarterectomy even if you cross.
yeah, as long as we're not in
That's
a
what I'm saying.
subintimal plane, because you don't want
That's
to
what I'm saying,
propagate
right?
that.
So,
Right.
I think we are actually very close to
No,
the...
but
I think
Say
it might be
018
in
Gladius.
actually be better, right?
No, but the problem, this is Halliburton or Gladius?
Gladius.
Gladius.
The only
This is Gladius?
reason to go
Gladius,
any
yeah,
further
it's
now
Gladius.
is just to
The previous one
get
you
more
used.
So
support,
it's
bury your wire so you can
Correct.
No,
track
no,
things.
it's not
Exactly.
hydrophilic.
That's what I was talking about. Just
What's
give you more
the Halliburton's
support.
hydrophilic?
Halliburton
Especially
is
the
hydrophilic.
sheet is getting
Why do you
kicked
want
back every time
hydrophilic,
you
PK?
do it.
You don't want
And we haven't
hydrophilic,
even
Because you want to get the balloon done
right
over
now.
there.
Yeah,
Low
but we have to
caliber
track
balloon.
on
Forget
a-
about
Yeah,
the
if you
bigger
were to
caliber.
cross, if you were to get like
Yeah.
a
Correct.
super core or something down.
Exactly.
You want
kind of
480
like
or 508?
cases kind of-
408.
480.
So the
So
other
do you
thing,
think it-
Stretch.
Go ahead, Ajit.
I was gonna say the other thing we could have done is we could have
cross.
put a sheath
Almost
from
so
below
close,
and
yeah.
then snared a wire through and through
That's what
too.
we did,
yeah.
Met in the middle. But
That's
Pretty
if
sure
we
that
were
was-
having
that was
trouble
said on
crossing,
this side
I
of the
wouldn't push
table.
it, yeah.
No, I'm not.
So what we're going to do is, you saw we that churned out for an 018 wire, and now we're going to go with a 40 balloon And I don't know, but
PK, you want to
whether-
IVUS? Just to see.
018 IVUS, guys.
We have it.
We have it.
No, just to get an idea whether how intraluminal, how subintimal you are.
See, Dr. Rao has a 12 o'clock lecture at V.
Sorry.
And we were like, we discussed not to IVUS, but of course you brought it up. And I will let Raman take care of you when he's done.
Yeah, you should have seen the look that
He already has
I
me.
just gave him.
I got it.
I have 2 bruises, upper torso, lower torso.
That's what I'm a little worried here.
IVUS is always a good decision.
I agree.
See? Thank you, Ajit.
Oh my
See?
God, Ajit, you're supporting Kapoor.
Oh,
It's one thing.
I didn't know I was taking
Raman,
sides.
Karthik, and myself
This
never do.
case is now officially sponsored by Philips.
All right, guys, Phillips, let's go on. Let's go live. So we're in the common femoral. We're going to switch out now.
Can we see the IVUS, please? Yeah, I think it gives, like you always speak and talk about, it gives a lot of
Sorry, bro.
information about where we are, how we are. In this case, you're right. It doesn't really matter because we
Screen?
already do a cut down. And we know we're going to treat it surgically.
All right,
Screening,
so
please.
here we're going to
Just
start.
to give a good idea. How
Can you
far
guys see
we
the
go.
IVUS?
Yes.
Yes,
All right, so we're in the common femoral. Not really fully Raman. We're on top of the common femoral, maybe the proximal.
Look at the calcium.
I didn't go any further,
270
and now
plus.
I'm slowly pushing
Yeah,
back.
you're in the vessel.
Yeah.
You're in the vessel in the common femoral. In the external iliac, you're in the dissection plane. So
That's a plane.
yeah,
No,
in
no,
the
no,
external
no,
iliac.
it's
no,
a
no.
plaque.
External, you are in the vessel.
You think so?
No,
Yeah,
external, we're in a
100%.
plane.
well,
I think
no, no.
at least
You know what? We'll do a run with ChromoFlow. Let's try
this
that.
looks like it's in,
There's
in
going
a
to be no
plane.
flow.
Yeah,
This is the
but-
vessel. Yeah,
This
there's
is
the
the
vessel.
There is the vessel.
Yeah.
whole thing
I-
was-
I think it was intraluminal.
I think
whole
I
thing
think
is the
Raman may be right.
vessel.
I think you're definitely in the vessel.
No,
Yeah.
the whole
Common
way.
femoral, we're definitely in the
Yeah,
vessel.
common femoral,
You're
definitely
definitely in the vessel,
intraluminal,
so-
which is good. That'll make it
So
easier.
the only question is, do we balloon? Okay, so now you saw the IVUS. So I'm just going to go with a 4-0, guys.
Correct.
And I'm going with a 4-0 balloon now, a 4-0-018. And then we're going to decide what to do here.
Is this just so you can track
Remember,
the size,
IVUS for
basically?
sizing as well. I mean, I know we
No, I'm
have
gonna make a
CTA
track
sizing
and then
in this case,
decide
so
what we're
hopefully
gonna
that
do.
should help. We don't need
I think
it.
I think
It's always
or
good
would
for
you
people who
crack
are not
and pig?
really
What do you
sure,
want? I don't think
especially
it'll
this is not a
track,
balloon
will it?
expandable stent.
No, I think
It's not that you can stretch
You wanna
the
put
stent
a
all the way
pre-dialing
as much
is-
as you
no,
want.
pre-dialing is good.
Yeah.
You want to put a
Usually
Y1
use a
first?
Y1,
No,
which is
no, right?
self-expandable
Yeah, you want to
stent. So
Endarterectomy
good
first
sizing.
and then put a
So
Y1.
unless you're
Because-
very good at your sizing technique, I think IVUS is a good option here for sizing, purely for
Got the
sizing of a
bag
Y1 stent.
The other
Yeah,
nice thing is
That's
it.
the only thing I
yeah.
would consider specifically in
I'll
this
use
case.
the other side as like a reference,
Yeah.
but you know, okay.
We have a CTO, but
okay.
yeah.
Learned.
The other thing that it
Fine,
shows
yeah.
us.
Raman agrees. Yes, sorry, Ajit.
The other thing that shows us is that basically the entire lumen all the way down is just
balloon
full
is
of
right.
plaque.
Correct.
Yeah.
There's
That's
not like
exactly what
any
it is.
healthy segment, so
Yeah.
you know that makes me more
Usually
likely to
with close,
just probably stent the whole external, you know, down to
Forward.
the common femoral.
Makes
Yeah.
sense.
Okay,
Just
we're-
as an aside, I think your wire may be. In
Yeah,
the
we already-
vessel.
Yeah,
Yeah.
we went through.
We
yeah.
saw that.
We
But it's
saw that.
amazing, like how
forward.
you are right that the calcification is more confined to the CFA
It's only
segment,
four.
while the
It's
iliac
Yeah.
segment is all soft black
Button.
in there, which
Yeah.
is true.
Everything
If the
okay?
CFA
Yeah.
wasn't that
Just double
calcified,
checking.
we would have even thought doing everything endovascular.
what-
Maybe
what
just do
pressure?
a DCB of the
10.
CFA and
Okay,
follow
walk
up.
it back now.
Yeah.
And
No,
if the DCB fails down the lane, then of course endarterectomy has always been an option. But in this case, we chose endarterectomy as our upfront strategy
so-
because of the degree of
Yeah.
calcification.
So
Yeah,
our
the Russell.
IVUS team is saying that our measurement is 9 guys.
I was.
So, Robin. he knows. It's true. That's what we're calling this, the IVUS team.
It is.
Come on,
We have
Robin.
a dedicated.
I like it. I like it.
By the time
So
Thursday
just-
Friday comes, the IVUS team is gone.
Just a question here. Guys, if you see the internal, it comes off close in the first angiogram. Down, guys. And I'll show it to you in a second. So when we put a vibe on, are we gonna lose this internal, or because we have the contralateral internal? Or what are your thoughts on that?
Well, we have an origin of the external, so we
Right.
can just start vibonding just at the nub.
Little dial there.
And definitely
Yeah.
try to preserve that hypogastric, you know, because that's providing collateral.
Okay, go
so
up there.
if there's any issues with the external in the
Yeah, I
future,
think
at
they have
least
a good
it's,
landing zone.
I just
for,
worry about the seal. You know, I just don't know
Yeah.
if we'll get a good seal. We'll see.
size. Yeah.
What if you were
Yeah.
to do
You can put a 7
like
and go with 9, right?
VBX,
You
like a VBX,
Right,
like
and
a
VBX,
proximal
and then the
external,
vibe, but it's
Yeah,
external
kind of
though.
focal.
that's
Down?
yeah,
but
you
it's
could
okay,
do.
right? You can do
Like a short
VBX.
Yeah.
VBX.
Yep,
Short
we
VBX.
agree.
No, we can go with the VBX and then take a 9.0 balloon and then expand.
Yeah, that's not a bad idea.
So let's
Yeah,
go with the
really nailed the
9.0.
Two-stent strategy.
We have enough space.
Yeah.
Two
there
stents
to-
and a patch.
Go up again.
Yeah.
But I think that's a good. I think that's a good point, though. If you're in a bad dissection, then you got to worry more about seal, right? Because you're not going to get
That's
much
why,
seal.
That's why
like,
I'm
with-
worried.
but I do think we're not in a. We might even be intraluminal most of the way down.
Yeah,
so.
that's what it looks like.
All right, DSA.
We have the IVAS team to let us know.
Yeah, it's in the DSA.
So
All
remember,
right, let's
guys,
see.
we're watching the pressure.
That
We're
looks
watching
pretty good.
everything.
That looks excellent, guys.
So we actually have flow, looks like now.
Do I even have to do the endarterectomy?
No,
Thank you, Ajay,
100%
for
we have
coming.
to. We have to do the endarterectomy.
I'm just kidding. There's a lot of plaque in that vessel. It's not
Yeah.
gonna work.
Yeah. So it's not really in the vessel.
It's in the vessel.
You know, it's kind
Oh,
of
yeah.
in the
Is it in
vessel.
the
In the
profunda?
profunda, yeah.
It's in the
Trying
profunda. It's in
to
the
make it
profunda.
profunda.
It's in the
So
profunda.
I'll just pull it out just to make sure it's not in the profunda.
And he's going to rewire it into the SFP.
No, I don't want to do that. I just want
No,
to.
can you please just thank you.
Yeah, see?
So
We get support.
Yeah,
All right, so we're in the
outstanding.
SFA.
Yeah.
We're
So
done.
now let's talk to everybody at home. So guys, as you saw, Dr. Rao, myself, Raman, the team, we're talking about that go scene minus to look at the nubbing of the external internal bifurcation. So no, minus one more. The idea is the seal. See, like you need to actually make sure you seal because there's always an issue. There is a little bit of a, I'd say, what,
Nub,
2 millimeter,
nub,
4
2
millimeter?
millimeter
maybe?
nub.
Yeah.
It may not be.
centimeters,
It may not be enough. So I think we'll decide. I mean, putting a balloon expandable stent gives us the ability to nail it, right, and also to expand it.
Expand
Right.
it.
So do we do distal to proximal or proximal to distal?
Distal to proximal.
I think, yeah,
Distal to
just
proximal, just to nail it.
I think that way your stents won't kind of get caught up
Yeah.
if you're trying to put a
Yeah.
stent through a stent.
Right.
So yeah, probably just
Perfect.
proximal.
And plus you can get the length.
Second question is, where do you land the distal
So
stent?
that's so I don't know if you can see on the screen, but those little loops, kind of, there's like a few of them.
Yep.
Those are the vessel loops. So that's where I got proximal control of the vessel.
So it's got to be past that.
So it's got to be just to it, at
Just
least to it.
So and now the sizing of the Vibon. 9.0, 8.0.
What was it was 9.
Ivan's size was a 9, right, guys?
Yeah.
What about
9.
distal? Distal external. Yeah, approximately it was 9 for sure.
So you want to put Viban and then VBX.
Yeah, Vibon distal VBX to land the
Yeah,
origin.
the origin.
I think, I mean, there's no reason to go crazy. 9 is a big enough vessel, so you could probably do a 9 or 10 VBX depending on the sheet
So
size.
9 VBX. Does it go through an 0.8 wire? No. So you think it'll track? I think so.
Well, you have
All right,
the
let's
wire
try a
down
960 or 980. What do you have, Mike?
Why not
So
just change out to
What do we
035
have?
system?
Yep.
Yeah.
Huh?
Wire
950.
load, yeah.
So we're doing the Vibon first, though, right?
Right.
You're doing the Viban
Not
first.
Yeah,
Vibon
we're doing the
first.
Vibon first.
Yeah.
Should. I think we'll do
9.7.5. All right, now we're going to change out for an 035 wire, so let's get the catheter down.
I would probably do
That
a
shouldn't be too long,
960, and then
Plus
whatever
flush.
just do the
Flush.
No, the
VBX.
75
Oh,
one.
we used what size? We used a 60 balloon, right?
Okay.
Then
We use the 60.
Yeah.
All right,
so
so that
we're
should be
fine.
fine.
probably longer than that.
Can I take a look here?
Yes,
so
please.
the
By 975.
I'm just going to change out the wire field,
Yeah.
and then we'll do it. Yep.
The-
And then
the
use
other-
an 8 VBX and expand to 10
Super
10
core.
at least. 10 and a half to already seal the proximal and proximal.
So again,
Probably
for
before the-
everybody at home, we're now changing out to a super core just to have. See, it's a little. It's not going to go.
Yeah, watch the sheet, I guess. But
Yeah, I know. That's what I'm worried about too. So let me.
Across.
Yeah, get a Navi cross, guys.
Yeah.
I agree. It's not going to go. It's going to push the sheet out there.
No.
Navi
So we
cross.
take a Navi
What an
cross.
excellent case, though, guys.
Navi
Yeah,
cross.
This is very, very nice.
Oh
I
my
think
God,
that-
yeah.
And again, this just really just goes to show again, just these complex cases. You'd be remiss to not spend the time beforehand, face to face, not even on the phone with your surgical colleagues, reviewing the films, reviewing the CT images to really make the best approach. And I think this goes to show that if you really spend the time and you make a really thought out plan, you are going to be able to stick to it.
Well, see, listen. I mean,
this is very nice. It's a great example of a collaborative effort to treat a very, very complex disease.
and Raman, what you're saying is absolutely true, but I think it's also for everybody at home, is that I know in prior practice, we're trying to make ends meet, surgeons, us, everyone. But, the truth of the matter is here, everybody does well. The surgical endarterectomy, the stent. If you're a cardiologist and you're doing this and decide to stent this, you're probably not going to do the right thing for the patient.
Correct.
And the patient may actually not do well. That's not going to go.
Yeah.
We have to balloon
I
this.
think it's very
No,
important,
my
like
sh-
Raman
my
talked
sheet.
about, planning of the case, both from an imaging perspective, from a clinical perspective, from the outcomes perspective.
Right.
And of course, what truly suffices for the
Let
patient.
me get
So I
the
think
wire a
it's
little bit down,
important,
okay?
so the success rate is high. People sometimes let me try to poke a wire, go ad hoc.
Okay.
It sounds very easy, simple. Even we try to do it sometimes.
Why don't we just wire
Endovascularly,
it
maybe we'll
from
just
there?
cross through
I don't
and
think it'll go.
everything will fly. But I think
What do
that's
you
not
want to
the
take a
right
chance?
approach. The
Leave
right
it. Let's
approach
just
is,
do a Viban on this.
like
No,
you
it
talked
went
about,
down.
just doing it as a
It did?
collaborative effort.
There,
so that the results
Nice.
come out
Good.
as
Have
good
to
as
threaten.
That's
we are
it. Just
hoping here. in
smile
this
and it
case.
pops through.
It will.
Our 035 wire.
So
Here's
yeah,
a
the other
super
important thing that
You just have to keep looking at
is
it
the
when you smile.
profunda, which is like a big reason to treat
Right.
this surgically. So I don't think all common femoral lesions are necessarily the same. You know, like
Yeah,
you have ones
100%.
that are higher risk. I think that involve the bifurcation of the profunda and SFA.
Yeah.
I still think surgical endarterectomy is the way to
The
go.
gold standard, no
Yeah.
question.
But this one is a higher risk one for sure.
Both of the guidelines also just came out, both of them saying the same thing, that if you have profunda disease involvement of your CFA, then endarterectomy is the way to go.
Correct.
Endovascular is 2B if you just don't have
250, give
Another
it
option
another
right
1,000.
Right.
Yeah.
It's all about involvement of the profunda.
Yeah.
The-
Now, just for the sake of curiosity, what would be the other? Let's say you were to do this in a purely surgical approach. What would be the order in which you would choose from your pure surgical options to treat this patient with no endo
9.5,
at
9,
all?
7.5.
Yeah, no, that's a great question. So the other options that you have, and like even if we weren't able to cross, fem is
What's
one.
the knees, right?
So that's probably what we do here. You
Would
could
you
also
do like a fem SFA, or would you just do like a fem profunda, a fem SFA, or would that also be accompanied with a endarterectomy?
Endarterectomy.
it's still an endarterectomy. So
Still
endarterectomy, the common femoral, and then a fem to that. Yeah.
Okay.
So that's one. Then you could do an aortobifem, but that's
That's an 8-inch.
Yeah, put it in.
the other side's
Just in
open.
case.
So
And that obviously
we can take
is
a
a much
8
more
OVBX,
invasive
right?
procedure
8
that
OVBX.
not a lot of patients
We
can
could,
tolerate,
but
depending on your
yeah,
patient
yeah,
population.
8 OVBX.
What's the additive morbidity with fem with
No,
the
9 goes to
isolated
8 inch.
CEA?
Phenomenal.
It doesn't add too much more
Yeah.
complexity
Yeah.
to do it because you have to cut down anyway.
Yeah.
Yeah, right.
The main issue is just access because now you have a graft in both sides,
Correct.
and then also you
By the
have
way-
graft in the groin, which is at risk, for an infection. So it's not my favorite. Out of all the bypasses, that's not my favorite one to do.
Fem is
so-
not your favorite.
No.
So this is a
Okay.
a 9
I'll do it.
VBX tracking super. I'm not a VBX, a Vibon.
Vibon.
Yeah, tracking super well, we hope. And it's where is it right there?
It's still in the
So I
So the
started
idea is
talking
to-
too soon.
Go to the femoral.
I know Raman's chuckling because he's like he can't see anything here. So that's why I went down. And I'm like
906
tracking
Very,
super.
Even I was trying to find it. I was like, where is it?
So yeah,
Ooh,
this is
right there.
the sheet.
Right.
We're gonna track the sheet back again. Okay, rail again. So Ajit wants it. Keep the sheet in the
Right at
center.
the clamp.
Yeah,
So I kind of want to mark it with a clamp,
that's good.
Yeah.
just to make sure that I can
beautiful.
clamp. I can
Nice.
put a clamp right through it.
So is that a good spot, Ajit, or you want to further?
Can I take a look?
Yeah, of
No,
course.
no. It's a,
So I
it's a
just
Vibon.
I can actually look in the incision and see how high up I can go, just to
Can
make
we
sure
please
that.
make sure we can get a camera over
Yeah.
the access site where
If
all
we
the
can.
action is actually going to be happening?
Can you show the
Yeah, I
access
can
site,
show-
guys?
Let me get a
Yeah.
Wheatlander.
And we got to maybe move this forward.
Yeah.
Let's see if we can get a shot, just so I can.
All right.
Great. We can maybe move the II out of the way.
Just a little bit. Yeah. So we can see the groin incision, and we can see the clamps. Yeah. Oh, nice.
Let's zoom in there. We give him like a GoPro so he can wear it on his head or something.
That would be nice, huh?
So this is I don't know if you can see, but this is the inguinal ligament right here.
Right.
And so
Uh-huh.
we really
Yeah, nice.
mobilized and we're able to push it up. And then these are all the vessel loops. So
Yes.
what I'm going to do is just mark how high I was able to dissect before it dove down. So that way we know to stent to
And
there. So that way I
further.
can just clamp there.
Beautiful. Yeah, we don't
But
need
yeah,
the
I don't
light.
know.
Yeah, that's good.
Excellent.
No light? Okay.
Do you need the light?
Yeah,
No, the light is
there's
on
a
his
pretty
head,
good
so
view.
he needs
He
it.
needs the light.
Yeah, I need the light. But
Sorry.
Raman's like,
blind.
does he need the light? He needs
Yeah,
the light.
That's where it is, right?
But that's
Oh,
there we go. That's a
beautiful.
good view.
Yeah.
So
very
that's
nice.
how. So now I'm gonna just fluoro that so we know exactly that our stent's distal enough.
So the
I think
stent,
that's the
you
easiest
want
way
the
to do it.
stent to cross just minimally across your clamping.
Yeah. So actually, what we have right now
Oh,
is
it's perfect,
perfect.
Maybe you can show the fluoro.
That-
Yeah.
Yeah. Let's
Oh,
go back to
great.
floor. Yeah.
Yeah. Great.
So you can see I'm gonna be able to just put a clamp on it. So that'll be
Nice.
perfect.
Perfect.
All
Deploy.
right.
Oh, that's good.
Huh?
Oh, your nose is good. So are you good here with this?
Yeah. I wouldn't let it come back at all, but it's
Yeah.
good where it is.
So since we now identified the spot, we're going to deploy the Vibon. Dr. Guja is deploying.
Ajit, any concern about the flexion point and the covered stent patency and all the stuff?
I think Vibons do well in
Walking
this
back now.
in this area, and I don't think we're too low. And this is like also a 9 Viabon, which is
That
going to
gives you
go
more
into
data.
a healthy vessel now once we do the endarterectomy. So I think
Right.
this will have a good patency.
Now we're going to get a. Now we're going to take a picture and decide on the VBX. Ready? DSA.
Yeah.
Oops, sorry.
PMHx,
It's so funny that Viabon actually looks small, so we had to balloon it.
Yeah.
That's why it's a big size. Even the SFA looked like a 7.0, so I'm sure we used a 9.0 Y-bond, but
Very good.
it looks good. Approximately,
Yeah.
I guess the vessel really increases in size.
So what's the size of VBX now?
9.0.
9.0?
Yeah, we
can
can always
do
we can always
8.0,
post dilate it.
9.0,
9.0,
37? 59, you think? 59.
59.
59.
9.0, 59, get enough seal.
Yeah.
Yeah,
8 59.
Yeah,
you can do 8 or 9 and go up to 12.
that's fine. We can always go
I
up.
mean, we are 8
Whatever
French,
we
and
have.
we can go.
Yeah,
I would
nine,
probably
eight
go
or
9.
Well,
9.
8 or 9.
959 is going to go to.
We can probably use the same
14.
balloon to balloon the distillage.
So now the reason we chose the 59 for those at home is we want to have the overlap and a seal from the Viabon into the VBX, or the VBX into the Viabon in this case.
It's 8 French, right?
And so therefore, that's even better. So therefore, we can actually go ahead and actually ensure a seal. I'm still concerned about the proximal seal. We'll figure that out because I think that's kind of,
You might have to balloon it with 10
with any movement, whether it will slip is what I'm worried about.
You might have to balloon it with
And
a 10
so maybe we should put a bare metal up top to secure it further. I don't know if that makes sense. But, it's just something to think about.
You can just
You
put a
break
10
the neck
balloon,
on the
right?
case anyway. May as well finish off.
Right.
No, but it's a huge vessel. That's
It's a
definitely-
huge
we don't
vessel.
it.
You have
It's
to put like
14
almost like a
vessel,
14
yeah.
stand.
It's
Yeah,
a
we
14
have
vessel.
the 14 self-expanding.
Approximately like
Laura?
a common. Yeah, easy.
Ray, fix the sheet, please. Thanks, brother.
So 9.0 could go up to 13, maybe also 14 if you stretch it. So, but you're right. A good overlap will decrease
That's what I
the
thought.
bias.
There you go. Beautiful.
Nice.
All right, let me see your little die. I think
That's
that's
a good
good,
spot.
huh?
That's
Well,
a
let's
good
go to
spot.
another view. Watch your knees, Ray. Okay, we're just now splaying out the internal external
But
bifurcation.
The 8
DSA?
large can go up to 16.
I think that's
Eight large
perfect.
is-
That's
yeah,
perfect.
you're right.
DSA, take a
Plenty of
picture for home.
space.
Yeah, you're right.
Plenty of
Eight
room. in
large
there.
can go.
So did you go with the 8L or do you have a 9 in there?
We went
9,
with the
9. We have a 9 in there.
Yeah, I think that's
We thought we might have to use
maybe
a 10
like
in the
a
proximal, no?
like a half a millimeter
down.
Yeah,
Half
come
a
down,
millimeter
right?
but
down.
it's a big hypogastric. So
But
maybe just
remember, we're going to
not
use a
gonna
10 balloon in the proximal, right?
Yeah.
In the seal, so it's going to foreshorten.
a little bit, yeah.
It's okay.
Yeah.
It'll
Okay
still
with
be
this?
fine. You have enough
Yeah, I think
overlap.
just deploy with like a little forward tension so
Laura?
it doesn't come back. But
No,
I think we have
you're
enough
right.
overlap between the stents.
All right, go.
And
go.
the hypogastric is
go
also
up.
very big.
Right.
So I think it's not going to really.
Yeah, you close it, goes
Buff a
a
little
little,
bit.
couple
Buff a little
millimeters.
bit.
Little
but
die
You
guy?
really have to
should
go
be
across
fine,
it to
yeah.
close it. You still
go.
have some flow behind it.
Yeah, we're fine.
Yeah,
It'll be okay.
That's good.
Yeah, yeah.
that'll be perfect. I think covered stenting is definitely the way to go here. Avoids any sort of embolization, rupture,
Keep it
and
up for
then
15, 20
probably
seconds.
a better patency overall.
Yeah, just in this we just have
What's
to probably
nominal,
push in a
guys?
little
I
bit,
mean,
so
to be
it
totally
doesn't
fair,
bug you.
I don't think I think there's any real room for a non-covered stent here.
No, he was trying to anchor it to make sure you don't lose
I think out
it.
of a few wrong things to do, I think that would be the only one, right? I think just considering it, I mean, wrong is always a very
We need a
tough
10 or
word
20
Very
balloon.
aggressive,
to
Down?
say, but
No, they want to keep it for 10,
Yeah,
15
especially
seconds.
like the
Really?
Cobest trial, is the one that's most
Yeah,
frequently
correct.
cited
They
that
did the
covered
anesthesia
stenting for
down
these
the
complex
stent.
lesions.
10 or
has
20
you
balloon.
do
They
that.
can do it.
have to,
10 or
right?
20 balloon.
So how long do you leave the balloon up with the VBX?
30 seconds.
Depends on the time of day.
But generally,
Like
15 to
maybe
20
10 to 30 seconds. But honestly, I think after a couple seconds, it's probably
well,
full expanding.
the newer VBXs are kind of sticky, and
Yeah.
we've had some that have been really a little sticky.
But I would say 30 seconds is a
James,
safe
can you
answer.
hold my mask up a little bit?
Sticky.
Yeah, I've had that too with the lower profile ones. So sometimes we have to swallow the balloon, and that helps.
Right,
kinda
and that's
get
the
it-
worry there.
Yeah.
So some of these, I've called Gore a couple of times during the situation.
You want
and
to take this balloon down and see?
Yeah, we're going to
Yeah,
try
yeah,
to go down. And they've told me the same thing, to swallow it and so on and so
Wait a
forth.
sec, wait a sec.
So now you can see we probably still don't have a good proximal seal. I don't think.
No, we don't. I took a 10
So,
balloon.
so now we're going to go forward with
Yeah,
this.
I'd
Back a
have to
little
go
bit and
10
then
or
go
even
back.
a
Go
12
back.
now.
Come back a
But
little
let's
bit
see.
and then go back and pick.
Yeah.
Come back a little bit and then.
No,
go
I
back.
think we should just take it out.
Oh, watch
Yeah.
watch
Yeah.
the sheet. Watch
yeah,
the
I
sheet.
know. I'm just taking it out. I would just take it out. It's not going to
Yeah.
go.
As long as it's not stuck.
It
Just
just
take it out.
take it out.
Yeah,
just
it's,
suck
there
it
you
out.
go. it's stuck again. So this is
Takes
I
time.
mean, Gore is aware of this problem, and I think they know. Of course, like I always tend to blame Dr. Kapoor when this happens, but this is definitely a real problem.
Hmm.
And,
There you go.
I think the stent came back a little
Then came
bit.
back. A little bit.
We'll foreshorten it.
Yeah, a little bit. We'll
Go up
do it.
higher.
Yeah, do the mid body and distal
Yeah.
and
10
foreshorten
balloon now?
right side.
Yeah.
Would you ever consider shockwave before putting the stents in, or is there no role?
No, we've
If
done it,
it's-
but I
we've
think
done
in
it,
this
but
case it wasn't
in
that
this case
it was
it's-
calcified, so we could have shockwaved and put the stent in, but then it would be an 018 system, and
Yeah.
I think that's the calcification is very
Yeah,
impressive.
very
The CSF,
mild. Yeah, very mild.
Yeah,
Yeah,
more of a
external.
plaque like Ajit was talking about. I think it was more prominent on the CFA aspect, which we're not anyways treating this way. So I think
let's go distal to proximal.
we
here.
could get away with shockwave and be
Yeah.
totally fine with it.
So I asked
Rail,
just
four.
earlier what would be the pure surgical option. So going around the room,
Go up here.
what would be if you were, remember now we did cross and degrade, what would be your pure endovascular therapies should you choose to do so?
Well, I think we talked. We should not choose to do so. What's nominal, guys? Here, 6.
That's
So-
that's
No,
number
it's a
one.
9 VBX.
But I think in our case,
balloon, right?
worst case as a salvage,
good.
if there is no
Yeah, that's fine.
surgical
Yeah,
option,
down-
no
that's
acute
fine.
Say
surgical
very
option.
hostile groin, so on and so
More
forth. You
redo
can't
all-
go redo
Yeah.
all that stuff,
So then
right?
probably do an atherectomy of a CFA with DCB and try to avoid any flow limiting dissection and let it heal. And then of course put a covered stent more proximally to have a straight inline flow.
Mm-hmm.
And then of course wash the patient clinically. I would not go stent up
gotta
front in
crack it.
CFA unless there is
Yeah, I'll
really a
crack it,
bad
I'll crack it.
dissection or it involves my profunda. Again, the idea is make sure the profunda stays
So
open.
despite the amount of dense
Recoil.
calcium you
Yeah,
see
recoil.
on,
Right, so if I
Yeah.
shockwave
Yeah.
it, atherectomy it, and DCB it, and I
You
get
have
a
to put
good
a
luminal
stent in there.
gain
you would
with
leave
no
it alone.
flow dissection, we just stop right here and then go from there. I mean, it's a big vessel size
Yeah.
as well. So I think that definitive therapy should survive the
Go
initial
down a little bit,
brunt.
Vicky.
So I think
A
it
little
should
bit.
work. I mean, like you
Yeah.
said, there are options. People do supera of CFAs, and we've talked about it, and they have bigger sizes now as well. So
Yeah.
it's another armamentarium in our stuff, but I would still stay away from it.
Yeah.
Unless
DK
I really
Guj,
have-
what about you guys?
We
In
are
the event
going.
that surgery is not an option.
I mean, if surgery is not an option, if this was if this was that kind of a case, I would have put a supera in.
The same pre-therapy, but plan.
Pre-therapy,
Shockwave,
do a
DCB?
DCB, shockwave, DCB, and then supera in.
upfront supera, or you'll see if there's any
Upfront supera. I think the data of the CFA stenting is pretty robust now. So I think it's, if you have to put it, I would not leave it with shockwave and supera. Shockwave and DCB. I think
Interesting.
the recoil is going to be pretty significant, and the failure of DCB now we definitely know the reason why DCB failure is number one reason is recoil, right? So it's not, the restenosis happens because of the recoil, not non-expansion.
DK,
So
where do you stand on this topic?
I think, to me, I mean, if it's really not a how can I say, a surgical groin, then I think I would probably go ahead and do supera, depending on the size matching of the
Yeah,
supera.
of course.
If I don't have a
Yeah.
size match, then I would probably do alluvia. But to me, I believe in these complex lesions, DCB alone doesn't work. So I would probably put a scaffold. That's my opinion. I don't know what you think, Ajit.
Yeah.
Yeah, I mean, I agree with you. I think if you can't do an endarterectomy, I'd probably
Work it
do
out.
either shock. For this
Plus or
case, I'd
minus,
probably do a
perfect.
shockwave,
Work it out.
plus or minus atherectomy and DCB. The only problem with putting a stent across the profunda is if that stent goes down, it compromises your profunda sometimes. So I don't, even though I know there's some data, but I would probably try to avoid it.
Great. Finally,
If-
somebody agrees with me.
Yeah.
If you don't
I will
have
say,
recoil.
so I think this
Do you
is also
say?
going to be my one of the academic year. Academic? No, calendar year, where I'm going to say
Very
I
nice,
actually
okay.
completely
Very
agree
nice.
with
Very
Guja
nice.
here. I think my plan up front would be to also
think it looks
supera.
You don't want to put a.
The
So,
only-
do you guys think there's a little recoil in the Viabond? Do you want to put in like a bare metal stent in the
no
Viabond?
PK.
I think it's
I would
like
not
less than
I would let-
20%.
Okay, well, I was it after.
Yeah, we
we
can
can
have
IVUS
this.
it after
Alright.
always.
So now
It's-
we're going to stop. Right now we're going to do the endarterectomy.
Yeah, I
Look at
think
the
Oh, yeah, I'd
beautiful,
love to watch. We have time to watch a
result
little
right
bit.
there. Proximally well sealed. We can of course
242
IVUS
ACT. You
confirm.
want to give more?
But the epigastric
Yeah, another
is,
1,000.
Another
the
1,000,
hypogastric
please,
is
Heparin.
open, and you have distally deployed it where we actually wanted to. So
That's low.
yeah, the common femoral is still occluded.
yeah,
so.
it's occluded.
That's right there. So leave it. Let's look now. Let's So let's focus on the common femoral for Dr. Rao. I mean, we're all going to learn together here how to do this and learn how to do this. It's going to be incredible. So the idea is to capture the scaffold, right? You want me to move the C arm out?
Yeah, we can move that out of the way.
Can we? How do you do
And
this?
then, Gene, we're ready. Can I get a large Wheatlander?
Got it.
So for this exposure, we already have proximal control high enough, but we need to get the profunda and SFA.
Chris?
Yeah.
Let me open it up.
See if we can try to zoom in a little bit.
I'll open it up.
Another large Wheatlander? You guys were too quick.
Well, we knew that Frank Veith would be very upset with you, so we're like we had to get you there.
Let's try to show it as best I can. But the loop up here is on proximal common femoral, and that's where our Vibon is. This is on the epigastric, which is below that. So we're not, even though the floor, we're not actually that low on the common femoral, still in the iliac up there. And then my distal loop is on the distal common femoral over here. So we need to get the profunda and SFA out because this plaque extends all the way down. Can I get an Army Navy?
So you're actually gonna excise the profunda and the SFA as well?
Yeah, we're gonna have to expose it because the plaque extends into the SFA and profunda.
Wow.
So we're gonna have to expose it so we can clamp it. And then the other challenging part about this is like a very long common femoral artery. So it's a pretty big exposure. That being said, I'm doing it through there's two ways to do an incision, transverse and longitudinal. And so I'm doing a transverse incision because I think it heals a little bit better. 2 DeBakey's. Okay. Really gotta retract here.
Yeah, you're right. You really have to pull down to expose your.
Yeah, just because it's so long.
Yeah.
So you guys never extend the incision; you just pull down with a clamp, right?
Yeah, you can get a lot of exposure by just retracting, and then you can get a smaller incision.
Got it.
So I try to use the retractor as much as I can.
Has there been any correlation with size of incision and infection and common femoral complications?
Yeah, I do think. Can I get Mets? I do think longitudinal incisions, like straight up and down incisions, tend to heal not as well.
Okay.
So that's why I always do transverse. The only downside is it's just you need to retract like this to really see everything.
Got it.
But a wound complication in the groin can be really devastating. If the artery gets infected and people can lose their legs. So I prefer it this way.
So in terms of your exposure now, you have some flow in the common femoral, so you're going to be bleeding as you expose the common femoral. Yes.
But he's going to use a...
Yeah, I'm going to have to use like what we call a Fogarty clamp, which has like these little inserts on it. And they're very good for calcium and stents. So
okay.
I don't know if I can try to show it, but this is like a good clamp. So this will be able to clamp the Vibon.
Ajit, when you clamp it, you have a stent up there which is freshly put in, right? So the lack of flow, you think will cause any issues with the stent because we are heparinized, you think it's okay?
Yeah, we got to make sure we're fully heparinized. And then I like to check ACTs, which we've been doing in this case.
But even with full heparin, lack of blood flow, stalling of blood flow in that stent, you think it's still okay?
Yeah, it should be fine.
So Manaka, maybe another
What
ACT?
about the integrity of the
draw an ACT,
the
guys.
stent graft itself? How do you assess that once you're done with it? Like, you're clamping it essentially, so I'm sure there's definitely some trauma. I know you told me Vibons take it well, but just
correct
for the integrity of determining that before you close it, make sure there is good flow down to that distal part of the clamp section of the stent. Is there any parameters you look for to determine that the stent is okay after you declamped it, so to say?
Yeah, I always do a completion angiogram. Can I get an angled one? I always do a completion angiogram just to make sure there's no clamp injuries. For common femoral artery lesions, endarterectomy, sometimes surgeons won't do it, but I always think it's just good practice because you can sometimes miss something even if you Doppler it. Right. So especially since we already have a sheath here, once we're done with endarterectomy, I'm going to do an angio from above and make sure everything looks good.
So what I thought was, as soon as Dr. Rao makes the incision and is able to capture the stent, the Vibon, and we can show everyone that, and then we can stay live for those who want to stay on, and then obviously we'll keep the recording going, and I'll be in here I know that our moderators may have to leave and Dr. Guja, but I'll be in here and I can talk this through with Dr. Rao. But I just want you guys to see this, how he's going to actually clamp it, or actually
Yep.
expose it, actually.
And so just to come out for a sec, Chris.
Okay, needs the C-arm again. And notice the hybrid room, how it helps everyone. See Dr. Rao right now needs the C-arm to look at this. So he's bringing it closer.
Because I actually want to make sure I'm clamping the vibe on with my, so we can actually see
You can
that.
actually bring it down.
Yeah, you're right. You're above the loop,
There you
the
go.
proximal loop where you actually had it
Yeah.
right there. So angiographically, it should.
So it looks like I'm just there.
Can we
below it.
quickly see the? Yeah, thank you.
Yep, you're definitely clamping
Yeah,
it.
so I'm definitely right at the very end of it. So I'm going to move my clamp up a little bit more, but then I should be good.
To get a better seal. Oh, okay.
So again, the hybrid room helps here to actually show that you're there. So why don't you just do it on the fluoro so this way we can see it and before you release it. Yep.
Yep, let me just,
So we're just going to show you here how this clamping and the proximal occlusion is going to work. So there is going to be bleeding regardless of you clamping, right? There's no question.
yeah, it's probably going to,
Very low.
it may bleed a little bit. Hopefully not. Don't jinx me.
We don't want to do that.
All right, so I'm right on the vibe on, but that should,
Yeah.
that should
you see
be
that
just,
distal dot too.
yeah, I
Yeah.
can always pull up on the vessel looper, you know, if I need to go higher. So I think that's pretty good.
So Ajit, the question, if you think clamping the Y-band and everything will have an issue, I mean, again, clamping the Y, clamp the Y-band, if you can actually balloon the vessel, do the endarterectomy and then stent it.
Why clamp
The
the vibe
reverse
on?
way. Like, why don't we do
He's
the
telling-
endarterectomy first,
Oh.
then put the Y-bands
Yeah, so
and
that's
everything
the other
in?
way to do it. I don't like doing it that way because when you do the endarterectomy, there's no endpoint proximally,
Yeah.
and sometimes you can create a bad dissection, or even worse, it can start to
So-
tear and stuff, and then it's gonna be harder to do the endo after.
Okay.
Ajit,
So
one more thought. How about I mean,
Left
I
hand?
know clamping. I know you said clamp and trauma. It doesn't really cost you the stent. But what if you do a balloon
11 blade?
occlusion proximally into the external, so it's a blood-free zone, and then you don't have to clamp the proximal end, and you can still work in so-called a blood-free zone. Would that be a thought?
Yeah, that's actually a great idea. I think if I was struggling getting my clamp on the vibe on, I would just inflate a balloon up top,
Interesting.
which I still may do actually, because if this clamp doesn't work, then that's kind of the next
I
step.
have another 10-0 balloon ready,
Yeah,
guys.
we have
We
it
have
there.
one?
We
On
have
the-
it
oh,
on,
we have
right
it
on
on
the
the wire.
table. We have it right on the
No
wire.
problem. Even better.
Even better, maybe we should just do that.
You want me to do that?
Let's
Oh,
see.
we'll wait.
Me
Let's
and
see.
Robert could have been surgeons.
Yeah, we might have to. Let's see.
Could have been surgeons.
Knife back.
Could have been surgeons.
Another debate.
Shall we talk about that statement?
No,
Yes.
keep going. Good job, Ajit.
Give me just 5 minutes. I'll be in the room with some of the scrubs, and I'll be
Helping you.
yeah. Second assist.
Army, Navy, or
First
Jamaica.
assist.
All right,
So
good.
I think
yeah,
you
that's-
guys jinxed me here. I think we might have to do that.
Okay, let's
just to
go
help.
with the balloon then. And balloon coming.
Balloon is there. Go.
We'll make sure it's not
Yep,
distal.
we're gonna need Flora though.
Okay.
So let me bring the Flora. Sorry,
I'm the guy in the suit.
Sorry.
Chris. Towards us.
Yep.
Karthik. Towards us.
264 ACT.
264 ACT. Little down, Karthik. Rail, guys.
I have it.
So we're just gonna balloon the mid portion of this Viabond.
Yeah, wherever you can put it is fine.
Right here. How's that?
That's
Okay, go up
perfect.
there, guys.
And this is a 10
The
balloon?
recoil,
10 mil.
yeah.
This is a 10 below.
All right, so that should be
So
good.
if I go nominal also, it will completely
Put it
upload
on the recoil segment, so that will just keep. It
Yeah.
Yep.
Yeah, because I just opened up a little part of the vessel and there's some bleeding. So this will confirm whether it's coming from forward or back bleeding.
That's good.
And the reason is this vessel is so calcified, so
Correct.
sometimes the clamps just don't
It's
work
not
well.
truly well, yeah. It's not completely occlusive.
Okay.
So.
Okay. Should be good.
Okay.
See if there's bleeding, so we can go up further. Up.
Yeah, go a little higher. Okay, that should be good. It must be distal then.
Okay. Good.
Okay.
Let me get this out of here for Chris.
Yeah.
I mean, you have internal connecting it too, right?
Yeah, to the profound.
Profunda.
So the profunda, so that might be a retrograde bleed too. So even though you have a clamp retrograde.
Sorry, Menachem.
Right angle. I'll try to show that plaque in just a minute.
Yeah, I think we're
264
going
is
back to
good,
the
bro.
Give another
surgical side
1,000,
if you can.
Menachem. Thank you. So ACT was 260 for those of you at home. So we're now giving another 1,000, trying to keep the ACT fully therapeutic.
Okay. Can we zoom back to the surgical side if you can? Yeah.
Yep. It's going to be hard to see because it's not a surgical room for us.
No, but
And
it's
the
still.
camera's
Hot
on.
scissors?
That's pretty good. Yeah, that's
Better
great.
than doing it
Yeah.
in room 4.
Oh my God, that would have been not a good thing. So I just want to see at least the artery open and exposure of the
Yeah, I'll
stent
show you that, and
of
then
the Vibon, and
we
then
can go
we
offline.
can we'll continue here while you guys can go. I know you guys have clinics.
11 blades.
So, Ajit, did you clamp the distal part as well, or not right now?
Yes.
Both.
Oh, okay. Good.
Yeah. So everything's clamped,
Nice.
and then I'm just trying to get through this hunk of calcium in the artery.
Distal clamp, Ajit, you do it right at the bifurcation.
Yeah, this one I did right at the bifurcation, just so I can show you the artery, and then I'll
Okay.
probably move it down a little bit.
Okay.
Move your bit to bacon. So this thing is so calcified, the knife is barely cutting into it.
Wow.
So, look like
Oh, your wire is still down here. I forgot. That's probably...
Should I move the wire?
No, it's okay now. We'll have to in a sec.
I can always pull it into the balloon if you want.
Yeah, we have room to pull it into
Yeah,
the
try
balloon.
to see if you can do
You
that.
just come back slowly.
If it doesn't go, I'll release the clamp.
It's coming back.
No.
No, it doesn't go. It's
Okay.
not coming back.
I mean, I can always pull it to the soft part
Yeah,
and then
pull
balloon
it back
up again.
now.
Pull back now.
I released the
But I have
clamp.
to come down on the
Oh,
balloon.
No, just leave the balloon. Leave the balloon.
Yeah. Yeah, see? There you go. Now you're in the balloon,
Perfect. Thank you.
for sure. You can take
Yeah,
it.
it's in- it's in-
Now, what's the
Fraser tip?
significance of the wire being still in that CFA while you're doing the endarterectomy?
It's just getting in the way. Because I need to pull the
It's
plaque out.
bothering Ajit.
Yeah.
That's the significance.
So I think I can show you enough here, just so you can see what it looks like. Can
Okay.
we try to zoom in a little bit on that, or
Yeah, if it, yeah.
There it is. Yep.
so?
Yeah, that's great. I can see it.
Yeah, it's a little hard to see, but you can see that there's a lot of this plaque, and it's like basically like as hard as bone. It's all calcium.
Wow. Yeah.
And so I'm going to open up more. This is just the start of it. This is what it looks like, and it's pretty fully,
Extensive down.
occlusive there.
So again, I mean, this is why it's a miracle that these stents even stay open and work in this kind of, plaque. I know Dr.
Yeah.
Marin used to say that all the time, that that the plaque is so hard that it's really incredible that these stents work.
Right.
So I think so you want to expose it, or do you think that they can see the Vibon and see that, or no?
Yeah, let me try. It's just
If
oozing
not,
a little
if
bit.
not, we'll come back.
Yeah, we can.
So
Grab the plaque and just yank it out? Like
Yeah, that's what I'm going to do.
Like a loose tooth?
That's what.
And a little more finesse, hopefully.
So what we're going to do then right now is, guys, we're going to stay on. Do you mind staying on?
Yeah, that's fine.
So we're going to stay on, and then I guess for the moderators, if you guys want to, if you need to rush, you can go.
Sure.
And then what we'll do is I'll moderate
Armin,
this with Dr. Rao, and then once we're done, we'll do a completion angio, so for everyone to see, and then we'll edit this obviously for the website. So at least from here, but as we're not signing off, but saying goodbye for now, really want to thank Dr. Rao and Chris for this incredible case. The anesthesia team, thank you very much. The OR team, thank you for coming here. And then obviously our team, thanks again. And maybe you guys can at least sign off officially, and then I'll come back to it.
All right, guys. Well, listen, this is a great combined effort. We get to see these not too often here at Mount Sinai, especially live. But this is a spectacular live hybrid case. Really, so much teaching that it's available at our grasp for today, and really was a great honor to be here today to watch this happen. That being said, thank you again for joining us. This case will be available for the rest of this case. Well, Dr. Rao is going to be exposing the rest of the CFA and sewing on the patch to the Vibon graft, and we look forward to seeing you again for our last broadcast for the calendar year on December 18th. And we'll see you right before Christmas. Everyone have a great day today at work, and we look forward to seeing you next month. Take care. Thank you very much.